Hello, my name is Matt Strehla from Stanford University, and this is the second part of our discussion about shock. Remember, we've been taking care of our patient, a 70-year-old woman who presented with fever and back pain, and we saw some early signs of shock on her initial evaluation. So, using our emergency medicine approach, we've now done our initial evaluation, thinking, and acting, and now we're at the point where we're re-evaluating the patient. On our re-evaluation, we're dividing these patients into those that are unstable or we thought may be sick, and those that were stable. And in this patient, we clearly decided based on her rapid respiratory rate, her borderline low blood pressure, and her fast heart rate that she was in our sick category. In the unstable patient, we're going to do a rapid evaluation, a little bit more thorough than our initial evaluation, but not full evaluation. Think about our differential diagnosis and begin our diagnostic testing and treatment as we go about these other things. So we gather our sample history in this patient, starting with the patient's symptoms. She was a 70-year-old female with fever and back pain. The onset was about 3 days ago. Nothing has made it better or worse. The pain is in the left middle part of the back, and she describes the pain as dull, not sharp. It started as a mild pain, but now it's progressed to severe, and it's been gradually worsening over time. Over the last about 24 hours, she's noticed some blood in her urine and has started vomiting. The remainder of our sample history is remarkable that she has an allergy to penicillin. She has takes a hypertension medication, and her only past medical history is hypertension. Her last meal was last night prior to arrival, but she vomited afterwards, and no other events to report. Now, what kind of focused physical exam are we going to do in this patient? Well, we're going to be focusing both on her complaint, which is the back pain and the fever, and also on other signs of shock. So we're going to be looking at her cardiac exam closely, her lung exam, her abdomen and back, her skin exam as we check her perfusion, and also her neuro exam. Probably not a full neuro exam like you do in a patient with a neurologic complaint, but definitely a neuro exam that's going to allow us to figure out her baseline mental status and whether she has any focal neurologic deficits that are obvious. Be careful though. If you don't identify a clear cause of the patient's shock on your reevaluation, history, and physical, you should continue to expand your differential and ask more questions and do a more thorough physical exam as you are resuscitating the patient. So on our patient's physical exam, the key findings were that she was febrile, tachycardic, had a borderline low blood pressure, or I would consider that low, and a respiratory rate of 30. It's always nice when the patient's blood pressure is low like that to ask them and see if they know what their baseline blood pressure is. Remember, this patient had a history of hypertension, so even if she's taking her medications, her baseline blood pressure might be quite a bit higher than that, and that could actually qualify her for septic shock. Her general appearance is that although she's alert, she does appear a little bit slowly responsive, and this is off her baseline according to her family. Her cardiac exam was unremarkable other than it being rapid. Her abdomen and back exam showed that she had percussion tenderness over her left flank. She was a little bit restless on her neurologic exam, but was moving all extremities and didn't have any focal deficits and was following commands. In her skin exam, she had hot, moist skin without a rash. We often categorize shock into different groupings. And here is a basic, very basic view of the circulatory system, where the blood is pumped from the heart to the arteries, it moves to the tissues, to the veins, and then back to the heart. Our categories of shock then are when the pump is not working, cardiogenic shock, when there is leaking or loss of fluid, there's not enough fluid in the circulatory system, and that can be in distributive shock or hypovolemic shock, or if there's a blockage in that system where the blood or fluid cannot flow by, obstructive shock. Remember, though, that although most patients have one category of shock that is predominating, multiple categories of shock may be going on simultaneously. And a good example of this is in a patient in septic shock. Well, they'll frequently have vasodilation or distributive shock, but they'll also have some cardiac dysfunction as well. Now, looking not at our categories, but our causes of shock. So if we look at cardiogenic shock, things we're going to think about, specific diagnoses, would be left ventricular failure, hypertensive emergency, whether the patient has a valvular dysfunction, a dysrhythmia, or acute coronary syndrome. Common causes of obstructive shock include cardiac tamponade, a PE, tension pneumothorax, or aortic dissection, which frequently at the end stages can lead to cardiac tamponade. Distributive shock, we're going to think about sepsis and anaphylaxis, and also neurogenic shock or an injury to the high spinal cord. Adrenal failure and mesenteric ischemia also can cause distributive shock as well. And then hypovolemic shock. Now, frequently people will put hypovolemic and distributive together, but I generally separate them out. And in hypovolemic shock, I think about bleeding, whether that's internally like gastrointestinal bleeding or a AAA, or externally like in trauma patients sometimes. And then I think about hypovolemia from severe dehydration. So back to our patient. We had our 70-year-old female with fever and back pain. She had some CVA tenderness, and we ask ourselves, what do we think the cause of this patient's shock is? Well, it's most likely infection, right? She most likely has a pyelonephritis, and she has septic shock. And what is the category of shock then that she would be in? That's distributive, right? So sepsis is in distributive shock, where we think we have an inadequate amount of fluid in the blood vessels for the system. Sepsis is typically defined as suspected infection, so not confirmed infection, but if the healthcare provider suspects infection, and signs of a whole body response. For the last decade or so, people have used the SIRS criteria, or Systemic Inflammatory Response Syndrome criteria. And these are tachycardia, heart rate greater than 90, an abnormally high or low temperature, tachypnea, so either an elevated respiratory rate or a low PCO2, or an abnormal WBC count, either being low, less than 4,000, or high, greater than 12. The SIRS criteria are useful to some degree though, but they alone are not the only signs of a whole body response. And one of the other things I like to throw in there is that the healthcare provider thinks the patient looks sick. So if you have a patient that you think looks sick and you think that it's probably due to an infection, that patient would be a patient I would classify as sepsis. That is an important group to distinguish, but the group that we really want to catch is those patients that are in severe sepsis and septic shock. So the severe sepsis patients are patients that have sepsis plus organ dysfunction. And in this table, I listed the common organ systems and the common dysfunctions that we would see, such as in the respiratory or pulmonary system, seeing hypoxia or respiratory failure. In the hematologic system, seeing low platelet count. In the hepatic system, starting to see a rise or elevation in that bilirubin. The cardiovascular system, hypotension. Neurologic, we start to see that depressed or altered mental status. And in the renal system, seeing a rising creatinine or a decreasing urine output as a sign of organ system dysfunction. So sepsis plus organ dysfunction is considered severe sepsis. Septic shock is considered sepsis plus hypotension, but it's hypotension after fluid resuscitation. So we want to take off those patients that were just a little bit volume depleted and that they responded to fluids, their blood pressure was good after that. That patient we wouldn't classify as septic shock. But in a patient where they have sepsis, their blood pressure is low, we give them significant fluid resuscitation, generally from 20 to 30 mLs per kilo bolus, and their blood pressure remains low or goes back down after that. Those patients we'd classify as septic shock. So in our patient, our initial diagnostic evaluation, and in most patients that we think are sick due to sepsis, we're going to get a complete blood count. We're going to check their electrolytes, their BUN and creatinine to check their renal function, the liver function test because we want to see if that bilirubin is rising or potentially what the cause of their sepsis is. A venous lactate can be useful. Cultures of the blood and the urine if appropriate. A chest radiograph is helpful both for detecting a source of infection, but it's also helpful in monitoring the patient over time for fluid overload as we resuscitate them. And then we want to consider any other disease-specific testing that we would need, such as if you think the patient may be at risk for malaria because you work in a place where malaria is endemic, or if the patient has fever and a returning traveler, or if you're going to get a lumbar puncture because you think the patient may have an intracranial infection and you're going to check the CSF. A brief aside about a lactate. So a lactate is used frequently to check for hypoperfusion. We all know that lactic acid or lactate is produced when a cell switches from an aerobic metabolism to an anaerobic metabolism. So when that cell is under oxidative stress, lactate will be produced. And what's been shown is that in patients that are sick and being admitted to the hospital with sepsis, that if their lactate is higher, their mortality rate is higher. So in this slide, you can see that if the patient's lactate was in that 0 to 2.4 range, which is pretty normal, that patient's mortality rate, the mortality rate was less than 5% or around 5% when being admitted to the hospital with sepsis. If the lactate was in that 2.5 to 4 range, the mortality rate rose significantly. It was kind of in that 5 to 10% range when being admitted to the hospital. Now, in the patients who had sepsis and their lactate was greater than 4, their mortality rate was dramatically elevated in that 25 to 30% range. This is equivalent to patients being admitted with septic shock. Be careful though, because I frequently see healthcare providers using a lactate cutoff of greater than 4 millimoles per liter to decide if it's normal or abnormal. And that is what is used often in studies, such as the early goal-directed therapy study that Manny Rivers conducted that really put a spotlight on sepsis, and in follow-up studies to that. However, a lactate is abnormal at any point greater than 2.5 in most patients, okay? And so if a patient is in that 2.5 to 4 range, that's still abnormal. That's still a sign of hypoperfusion and severe sepsis. It is not a marker that the patient has a dramatically elevated mortality risk like it would be if the lactate was over 4, but we don't want to consider that normal, and it's something we should still follow. So in summary, we want to do a focused exam identifying the most common causes of shock, such as infection, heart failure, bleeding. We want to identify the category of shock because to some degree this will help us decide about therapy. And then we want to recognize signs of organ dysfunction early to decide if that patient's in sepsis, severe sepsis, or septic shock. Thank you.